So the tumor is actually not present in the adrenals. It is present somewhere else. And one of the most notorious places is the lung. So a small cell carcinoma of lung may present with paraneoplastic features. So, what is the pathogenesis of paraneoplastic syndromes? It is because the number one or the main pathogenesis includes that a tumor produces hormone like proteins. They are equal to, or they are similar to those hormones which are actually produced by the main organ itself. So that is why we are considering them as like hormones. We are not calling them hormone. So they are not producing like hormones. So ACTH like hormone is produced by a small cell carcinoma of lung, which can produce same sign and symptoms as that produced by the increased ACTH. So there may be metabolism of steroids by the tumor. There may be production of some fetal proteins, then cytokines and other antibodies. So the main pathogenesis stays as production of like hormones. So these are some of the paraneoplastic syndromes. There is a long list. You have to see all those in your book. But see this Cushing syndrome, there is an excess of steroids in the body leading to moon phase and increase in the weight. So as you have already done this in physiology, same symptoms are produced if it is a paraneoplastic syndrome. So see this Cushing syndrome on the top. So corticotropin like hormone is produced by small cell carcinoma of lung, carcinoid tumor from lung, medullary thyroid carcinoma, and a pheochromocytoma. Pheochromocytoma is the tumor of adrenal gland. Then other syndromes include hypercalcemia. On second uh, place, the most important paraneoplastic syndrome includes hypercalcemia. Hypercalcemia is increase in the calcium in the blood. So it is because of the production of parathyroid-like hormone or parathyroid hormone-related peptide. Again, small cell carcinoma, squamous cell carcinoma of the lung. They are one of the notorious culprits of such symptoms. Other may include acromegaly, may include gynecomastia, and certain other symptoms. But whenever a patient is coming up with these symptoms, you are going to put tumor at last in your differential diagnosis. You have to rule out the main disease first, as in case of Cushing syndrome or as in case of hypercalcemia. You first have to look for anything wrong with the parathyroid or the adrenal first. Then you may go to any of the tumors. So in the list, you may see that small cell carcinomas, which are actually the tumors of the neuroendocrine cells, they are one of the top culprits in producing such kind of syndromes. This picture shows skin condition. This is called acanthosis nigrans. Acanthosis nigrans is that you have a black thickened skin just like leather. So the hand and the feet, they show areas of leather-like thick disease. Another important area you may see in this case is the nape of the neck and the axilla. The nape of the neck and the axilla. In cases of axilla and nape of the neck, uh, one of the most important tumor related to acanthosis nigrans is carcinoma stomach. So sometimes if you don't have a particular symptom related to any of the skin diseases, and the skin is thickened and you don't have another diagnosis for a dermatological pathology, you may think about carcinoma stomach. This is clubbing of nails on fingers. This is actually edema, which is just popping out the nails. So this clubbing of fingers is related to lung failure, is related to liver failure. You have to rule out these common things first, and then you can have lung carcinoma, which can produce this type of uh, features. So, proceeding further, grading and staging of a tumor. We have already discussed the grade of the tumor. I'm going to revise that first. But uh, to start with, make it very, very clear that grading and staging, they are two different things. You may be asked that what is the difference between a grade and the stage of a tumor, and as a clinician one must know that what is a grade and what is a stage. A grade of a tumor is uh, on the microscopy. A grade of a tumor is actually a grade of a tumor is actually depicting the aggressiveness of the tumor or the feature of the tumor on the microscopy. The stage of the tumor may be of two types. One is a pathological stage that is determined by a pathologist on gross examination of the specimen and then the microscopy, and secondly by the clinician. So the actual stage of the tumor is by the clinician. When we write a pathology report, we give a stage that is called a pathological stage that may differ from a clinical stage, because the stage of the tumor is determined after combining the history, examination, operative findings, the investigations, and the pathology report of the specimen, the tumor specimen. So the grade of the tumor may vary with stage. A high grade tumor may have low stage. Grade tumor may have a very high stage. The stage of the tumor is usually from 1 to 4. So we are going to go into the detail of these things now. So a grading is based on the microscopic features of the cell, how the tumor is composed, how aggressive the tumor is, what is the mitotic activity in the tumor, what is the shape, the face, or the features of the tumor on the microscope. Stage is based on clinical, radiological, and surgical criteria. Tumor size, involvement of the regional lymph nodes, presence of metastasis, which is determined on radiological investigation. Dysplasia is an architectural disorganization. So a tumor is always preceded by dysplasia. Hyperplasia, metaplasia are reversible adaptations, but if a cell develops dysplasia, it is going to convert into a neoplasia. So a dysplasia is actually a difference in the nuclear cytoplasmic ratio. So whenever there is dysplasia, it is an indication that the site may develop a neoplasia after a time or so, depending upon the site and the environmental factors, the genetic. Uh, dysplasia is always determined microscopically. Dysplasia cannot be seen on cross examination or clinically. Dysplasia have no features or clinically, or you cannot say anything about dysplasia in the clinic. Only the biopsy can tell that whether there is dysplasia or not. So dysplasia can be mild, moderate, or severe. Severe dysplasia is actually carcinoma in situ in case of epithelial malignancies. Nowadays, there is two-tier system. You only say low-grade dysplasia or high-grade dysplasia at certain points or tissues of the body, but at others you we are still using the three tier system, which is mild, moderate, and severe. So when a pathologist is reporting, there may be a discrepancy between two pathologists, as one can say that it is a mild dysplasia, other may say that it is a moderate dysplasia, but um there is not going to be any harm to the patient. But if one of the pathologists is saying that it is a mild dysplasia and other is saying that it is a carcinoma in situ, that is something important for the patient. So at certain points in the body, in the certain classification of certain neoplasias of some of the tissues, they have turned this three-tier system into a two-tier system, calling it just low-grade or high-grade dysplasia, so that the discrepancies, they are rectified. This is a normal epithelium. This is a stratified squamous epithelium. So you have a basement membrane, you have layers of epithelium. So this is the basement membrane. You have this connective tissue down there. This is what dysplasia is. If you see the previous picture, you have normal cells, polygonal cells. You have similar nuclei with similar shapes. You don't have any features of malignancy. But if you see this picture on my right hand side, you may see hyperchromasia. You may see pleomorphism with different shapes and sizes of the nuclei. So this is somewhat normal, but look at this. This is dysplasia. So this is again dysplasia. So this is the connective tissue, this is the epithelium, and you have a dysplasia. In cases of epithelium having more than one layer, uh, to call it mild, moderate, and severe dysplasia, it is that if one half of if one third of the epithelium is involved, it is mild. If two-third is involved, it is moderate. And if full epithelium, the full thickness of the epithelium is involved, it is a severe dysplasia. And a severe dysplasia is actually equal to carcinoma in situ. So this is important for the clinician. It is not just something to be remembered by the pathologist. It is because a clinician has to read a report which will say that this is dysplasia or not. So the clinician must be aware of what dysplasia is. Look at this. This is stratified squamous epithelium in case of a cervix, ectocervix. This is normal. CIN means cervical intraepithelial neoplasia. Actually, this is carcinoma in situ. So dysplasia, whenever dysplasia starts in a multi-layered epithelium, it starts from the cells near the basement membrane, and then it is going upwards. So you have CIN1, CIN2, and CIN3. You can clearly see what the difference is. So a tumor grade may be a low grade or a high grade depending upon the features. What are the features? Features include marked pleomorphism. Features include the mitotic activity. Features include the presence of tumor necrosis, and features include the surrounding invasion of the tissue. So a grade may be low, grade may be high, or grade may be intermediate. So a grade again is important in treatment, because the chemotherapy or the radiotherapy is given accordingly according to the grade. So whenever we are reporting a tumor, we are going to write it as grade 1, 2, or 3. Grade 1, 2, or 3 is equal to mild, moderate, and severe grade. So that is low, intermediate, or high grade. Just to show you, you are going to study this in detail in your fourth year. This is one of the grading systems used for prostate. So what we talked till the previous slide was a journal concept of grading, but you have a few differences in grading according to the tissues. So all those differences you are going to study in detail in particular tissues in your fourth year. This is to show you the grading system or scale for prostatic adenocarcinoma. This scale is called Gleason scoring scale. So this is how we, as a pathologist, give our report whenever there is adenocarcinoma of prostate. We are going to give a grade, and accordingly, the urologist or the oncologist is going to treat the tumor. This is a liver, and there is a tumor in the liver. You can see a well circumscribed lesion. So, in case of gross examination, the size of the tumor is important. So, the size of the tumor is important in pathological staging as well as in clinical staging. Again, see this. This is a hepatocellular carcinoma. The previous one was a benign tumor, hepatic adenoma. So it was a well demarcated benign neoplasm. But in case of this, again, hepatocellular carcinoma is a well circumscribed tumor. So this is a piece of a liver with a tumor. So make it very clear again, we discussed previously that what is the difference between encapsulation and circumscription. Circumscription is just a shape. That means that a round or a spherical tumor. A benign tumor can be well circumscribed. A malignant tumor can be well circumscribed. But malignant tumors are never encapsulated. Only the benign tumors are encapsulated. So a malignant tumor can be well circumscribed also. In cases of the size of the tumor, for example, I am giving you two examples. In case of breast carcinoma, if you have tumor less than 2 centimeter, it is stage 1. 2 to 5 centimeters, it is stage 2, and more than 5 centimeter, it is stage 3. So as a pathologist, when we get a specimen of mastectomy, we are going to measure the tumor, and we are going to write the size of the tumor in the report. Same way in cases of kidney, if you have a tumor less than 5 centimeter, it is stage 1, 5 to 7 is stage 2, and more than 7 is a stage 3. So uh, the size of the tumor is again important in staging. So malignant tumor may have lymphovascular invasion. Lymphovascular invasion can be seen in grossly if there is invasion of the larger sized vessels, like in cases of renal vessels in the hilum, and in cases of vessels in the hilum of the lung. But in cases of small vessels, you have to look for the invasion on the microscopy. This picture shows a liver with multiple um, lesions, and these are actually the metastatic deposit of a tumor in of a malignant tumor in a liver. So in case of metastatic deposits, they are most often they are multiple in number. That is because of the blood supply, and that is that one cell traveling in the bloodstream may lodge anywhere in the tissue and may form a similar tumor as the primary site. So in case of stages of the cancer, stage 1 is that it is confined to the site of origin. Stage 2 is cancer is locally invading. Stage 3 is that it is spreading to the regional structures. That also includes the regional lymph nodes. and stage 4 is that it is spreading to a distant site. So in cases of tumors in the abdomen, if the tumor is invading the peritoneum, it is going to be stage 4 automatically. So all those organs having peritoneal lining on the surface, if the tumor invades the peritoneum, it is going to be stage 4. So this is a general staging of the tumor, but you may have a certain differences according to the tissue, which you, again, you are going to go into the details of those in your fourth year when you are going to uh, study the individual tumors in the so stage 1 is localized, stage 2 is early local invasion, stage 3 is an advanced regional invasion, and stage 4 is distant metastasis. We call stage 0 as carcinoma in situ or grade 3 dysplasia. And this is for the epithelial malignancies. Again, giving you an example, this is colon. So stage 0 is going to be high grade dysplasia or carcinoma in situ in the epithelium of the colon. You all know that there are 4 layers of colon. So you have mucosa, submucosa, muscularis, and adventitia or the serosa. If you have a tumor invading the submucosa, it is stage 1. If it is invading the muscularis, it is stage 2. If it is invading the adventitia, it is stage 3. And if it is invading the serosal surface of any organ or going to any of the distant organs, it is going to be stage 4. This is also called Duke classification of staging a colon or a colonic carcinoma. Again, in fourth year, you are going to go into the details of these, but in general, in third year, you must know that what is staging. So, in case of pathological staging, we as a pathologist can give stage up to stage 3 in our report, but if it is stage 4, if the serosal surface is involved, we may give stage 4, but we are going to write it as pathological stage 4. Further, the clinician is going to determine that whether it is stage 4 or not by considering all the other prerequisites. So there is a system of staging a tumor. This is a journal system that is called the TNM system. It is according to WHO, and WHO system is the TNM system all over the world. The same staging system is used for all the tumor, and this staging system may again differ uh, according to the individual tissues or the organs or the sites, but the basis of the system remains as such. T and M means tumor spread or tumor, N means node or lymph nodes, and M means metastasis or presence of a distant metastasis. So TNM is, T means tumor, so that is actually the size of the tumor. T0, T1, 2, 3. So again, it is according to the pathological staging that we may give the size of the tumor in our report as a pathologist. If we get the lymph nodes along with the specimen resected by the surgeon, a degree of local invasion can be determined on the microscope and a gross examination. And similarly, if we get the lymph nodes, we can see under the microscopes whether they are involved or not. And we have to count the lymph nodes which are involved, and we are going to give the number of lymph nodes which are involved. Extent of the spread, that is distant metastasis, that is not determined by the pathologist, that is determined by the uh, clinician on the radiological examination. So T is the tumor size, and means the nodes, and nodes include the regional lymph nodes. For example, if there is a breast carcinoma, you have to resect the axillary lymph nodes, and if we are getting the axillary lymph nodes, we are going to uh, see how many lymph nodes are involved, and we are going to write them in the report. So as a pathologist, can give T, I can give N, but I cannot give M in my report. So in case of T, I'm going to write the size of the tumor that is going to determine the T in this staging. So for example, if it is a breast carcinoma of 3 centimeters, that is going to be stage T2. So I'm going to write T2. N is whether lymph nodes are involved or not. If they are not involved, I'm going to write 0. If they are involved and only 1 to 3 lymph nodes are involved, it is going to be node 1. And if they are more than 3, it is going to be N2. And in case of distant metastasis, I'm going to write X, that X, small
So
x.
sorry to interrupt you. Time is over now.
Okay. So I'm leaving the lecture here, and we are going to continue the lecture from this very slide in the next uh, sitting.